This is a consideration of the diagnosis of acute mania and hypomania. Symptoms of mania can be initially conceptualized as mirror images of symptoms of depression. It's a little bit more complicated than that. So these symptoms can occur in the affective, cognitive, and behavioral realm. And certainly if you look at the early stages of mood elevation, where you can see euphoria, affectability, irritability, grandiosity, increased impulsivity, if you like, racing thoughts, as well as increased activity, speech, and spending. This looks a little bit like the opposite of the symptoms of depression. However, as this progresses, it starts to get more complicated, and you can get an increasing number of mixed symptoms, and you can get increased behavioral disruption, so that by the time you get into the most severe stages of mania, you can get psychotic symptoms, severe behavioral disruptions, and something that we're going to talk about in a separate presentation. You can actually get a mixture of manic and depressive symptoms. So DSM-5 has some changes in the definition of mania compared to DSM-4. And one of the important ones of those is this inclusion of increased activity or energy as a core mood elevation symptom. So if we look at the diagnosis of a manic episode in DSM-4 and DSM-5, there's quite a bit of commonality there. It largely overlaps, although there is the additional requirement as a core symptom of increased energy and activity. The other core symptoms, being abnormally euphoric, expansive, or irritable mood, are the same. Now, there are some important differences between manic and hypomanic episodes. Those are highlighted in red on this slide. So the minimum duration for a manic episode is 1 week or hospitalization. So it can be briefer if the patient is hospitalized. And then the symptom counting, it includes 3 or 4 if the mood is merely irritable, additional symptoms besides the core symptoms. And these include things that are largely sort of mirror image symptoms of depressive symptoms. So inflated self-esteem, over-talkativeness, distractibility, impulsivity, decreased need for sleep, racing thoughts, and increased goal-directed activity or psychomotor agitation. Now, another way that manic episodes differ importantly from depressive episodes is that by definition they are severe. So they must entail psychosis, hospitalization, and marked psychosocial or occupational impairment. And then in common with the diagnosis of hypomania, a hypomanic episode, manic episodes have exclusions for secondary phenomena, so that episodes of mood elevation related to medical disorders and substance abuse are excluded. So we'll look at hypomanic episodes built in the same way. We see that the first bullet there is the same as the prior slide, with the exception of there's now a minimal duration of 4 days instead of a week or hospitalization. The symptom counting is the same as in a manic episode. There needs to be a clear, objective change in mood and function, and that's because hypomanic episodes can be substantially milder than manic episodes. And importantly, in contrast to manic episodes, and in keeping with that notion that they are milder, these cannot entail psychosis, hospitalization, or marked social or occupational impairment. In common with manic episodes, there is an exclusion for secondary problems. So the nosology of bipolar disorder is built similarly in DSM-4 and DSM-5, starting with the episodes and working upwards from there. And so bipolar 1 disorder requires at least 1 manic episode. These have a duration criterion of at at least a week or hospitalization. And most of the patients, but it's not required, also have depressive episodes, which have a minimum duration of a couple of weeks. And bipolar 1 disorder has certain illness characteristics. They're a little bit at variance with bipolar 2 disorder. These are considered to help confirm some of the differences between bipolar 1 and bipolar 2 disorder, but are not crucial to the diagnosis of either disorder. So how can bipolar disorder evolve? Here's one possible evolution for bipolar 1 disorder. So a patient has an acute manic episode, and this mania has to last at least 7 days or hospitalization. And very, very commonly, such episodes are followed by depressive episodes. This is not a requirement, but there's a model that one thinks that perhaps during the mania, neurotransmitters are being burned up at an unsustainable rate, and this causes the subsequent depression. Post-mania depressions are commonly twice as long as manias, and to be a major depressive episode, of course, there's a minimum requirement of 14 days. Then after a patient has been well for a couple of months, so after the complete mood cycle's finished and mood's been level for a couple of months, we have remission, and a full remission is considered to be after 2 months. So in that period, while the improvement is consolidating, there's a sense that, although not evident, there may be a covert episode at the time. But by the time you get 2 months out, the thinking is that underneath the medicine or whatever treatment, there is no mood episode. So bipolar 2 disorder is also described in terms of episodes, and there's a requirement here to both have hypomanias and depressions. Okay, so depressions are not required in bipolar 1, although the vast majority of patients have them. They are required in bipolar 2. Now, bipolar 2 has slightly different illness characteristics from bipolar 1. There may be a temptation to think of bipolar 2 as bipolar light, but these patients have a lot more depression than bipolar 1 patients. They can have rapid cycling, they can have other negative illness characteristics. There are even some data that suggests that suicide is more common in bipolar 2 than bipolar 1, perhaps because they have so much depression. However, by definition, there is no psychosis or hospitalization during mood elevation in bipolar 2, and actually it's much less frequent during depression in bipolar 2 as well. So psychosis and hospitalization overall is less common in bipolar 2 than bipolar 1. So here's a possible evolution of bipolar 2 disorder, in this case starting with a major depressive episode, and this is followed by a hypomanic episode. Remember, patients with bipolar 2 disorder have to have hypomanic episodes but can't have manic episodes. This in turn is followed by a period of consolidation, of improvement after the hypomanic episode resolves, so that by the time 2 months is up, it is considered that the patient is in remission, or if you like, recovery, and there is no covert episode present beneath the treatment. So DSM-4 and DSM-5 differ somewhat with respect to secondary mood disorders. And in this instance, we're looking at secondary mood disorders with manic features. And what we see here is that substance-induced mood disorders and medical-induced mood disorders are defined broadly similarly in the two. However, an antidepressant-induced mood elevation is considered a secondary mood disorder in DSM-4, but it is considered as sufficient evidence for bipolar disorder in DSM-5. And here's a schema with the evolution of that kind of an episode. So a patient gets depressed, an antidepressant is administered, the patient within 3 months has an episode of mood elevation. In this case, it was a manic episode. And so by DSM-4, this would be an antidepressant-induced mood episode with manic features in the context of major depressive disorder. Importantly, such patients carry a very high risk of spontaneous mood elevation episodes, and some authors have even called this bipolar 3 in the past. In DSM-5, this is now considered sufficient evidence for a bipolar disorder. So amongst the main changes for bipolar and related disorders in DSM-5 is what we just mentioned, that antidepressant switching, that is a full manic or hypomanic episode emerging during antidepressant treatment and persisting beyond the physiological treatment effect, is now considered sufficient to diagnose a manic or hypomanic episode and therefore bipolar disorder. So in conclusion, the diagnosis of acute mania and hypomania depends crucially on mood elevation symptoms, which broadly thought of are kind of opposite to depression symptoms. There is a change in DSM-5 where increased energy or activity is considered a core symptom, along with abnormally euphoric, expansive, or irritable mood. When we're looking at hypomania versus mania, we see some differences. Hypomania is shorter and less severe. That is, so hypomania does not include psychosis, hospitalization, or impairment. And in DSM-5, we have another change where treatment-emergent affective switch is considered sufficient evidence to diagnose bipolar disorder.